The lecture now is the left ventricular systolic function. Initially, we are going to use M mode. The initial method we used to evaluate the left ventricular function as ejection fraction was using M mode since the very beginning of echocardiography, and yet today we still use the left ventricular short diameter M mode. To evaluate the ejection fraction by the M mode, we must make several assumptions. To start with, we should assume that the left ventricular cavity has a geometry called a revolution or rotational ellipsoid. What kind of ellipsoid is this? It is a geometric figure that looks like an ellipse. But since an ellipse is a two-dimensional figure, we consider it is doing a revolution in space, rotating over its long axis. Then it becomes a three-dimensional figure, so we could measure its volume in a picture like that if we know its anterior-posterior diameter, the so-called short X of the left ventricle, that we measured by M mode. We should know its lateral medial diameter, since it equals the anterior-posterior diameter as it rotates in space. Then, if we know D1 here, we know also D2. In this kind of ellipsoid, we also assume that its long X, L, is twice the length of D1. If we accept all these assumptions by measuring just the short X, it would be possible to know the volume of the left ventricle, since the volume of a revolution ellipsoid is calculated by this equation. If we know that D2 equals D1 and L equals 2 times D1, then solving this equation, we would have that the volume equals D1 cubed. Believe it or not, this is still the way most of the volumes of the left ventricle are calculated. If we cube the diastolic short X, we have the diastolic volume. And if the systolic short X, we have the systolic volume. Then the ejection volume is the diastolic volume less the systolic volume. And the ejection fraction, the ejection volume by the diastolic volume times 100. It is an easy, rapid, and reproducible method, and all the echo machines do almost automatically, although certainly it is not accurate. Then, using a 2D echo parasternal long X view of the left ventricle as a direction to set the M mode cursor as perpendicular as possible, the long X, just at the tips of the mitral valve, in most cases we are not able to set it perpendicular to the long X. Hence, the minor X that we measure is usually oblique and a little longer than the right perpendicular short X. Here we obtain this M mode with the right ventricle, the interventricular septum, and the left ventricle, the posterior wall of the left ventricle, and the pericardium. Moreover, here we measure during the EKG QRS the short X during diastole, from the left ventricle side of the IVS to the endocardium of the posterior wall, which is cubed to give us the diastolic volume. The best way to measure the systolic diameter is from the peak of the posterior wall to the IVS. If this diameter is cubed, then we have the systolic volume of the left ventricle. Then, the ejection volume equals the diastolic volume less the systolic volume, and the ejection fraction, the ejection volume by the diastolic volume times 100. Now, let's analyze the problems with this method? There are many. Do you think it is acceptable that the left ventricle is shaped like a revolution ellipsoid? The left ventricle is much more complicated than this simple figure. How can one believe that a complex cavity like this, the volume can be known by a single measurement of its cube diameter? Let me ask you, which is the real geometric figure that we obtain its volume by cubing only one measure of its size? Well, it's a cube. Goodness, we are using the same geometric equation to evaluate the volume of the cube to estimate the volume of the left ventricle. It stands to reason that for sure it may not be accurate. To believe that we are going to obtain with only a diameter the volume and the ejection fraction of the left ventricle is a fantasy. This volume analysis needs that one is confident that the M-mode cursor is always possible to be directed the most perpendicular as possible to the long axis. Remember this, the short axis by definition is the one perpendicular to the long axis of the left ventricle, obtained at the chords close to the tips of the mitral valve. One can reach the tip of the mitral valve or the region of the chords using several different angles that would result in values other than the perpendicular one. Except by knowing where the long axis is, this image, for instance, the more perpendicular would be this one here. Most of the time it's not perpendicular, but we have to try to define the best angle related to the long axis. We see that in a long axis view, we know where the long axis is and then try to be more perpendicular to it as possible. And we know the area of the chords and the tips of the mitral to ascertain that we are doing the correct measurement with the best angle and position possible. Notice that one could reach the chords or the tips of the mitral valve going as oblique as this angle or this other angle here, and it would not be possible to compare with future measurements if we do not see the long axis. Here is the long axis, and I am verifying that this is the best M-mode cursor position to follow the rules. If I try to be more perpendicular to that long axis by moving the cursor more apically, I would be on top of the papillary muscle. Then this is the best position I can achieve. And I know that if the patient returns next month for a comparison, I can obtain close to the same location the measurement. Notice that although not accurate for volume analysis, this measure is very precise. On repeating it some other moment, I should not have any essential variations. In other words, if I obtain an ejection fraction by this method, it indeed may be far away from the real one. It is certainly not accurate, but I know that if I am to repeat that ejection fraction shortly, it would be the most precise I can have. This is very important in some situations, as in patients with chemotherapy. If I try to obtain the same measurement from a short axis view from the left ventricle, it would be tough to repeat it shortly, since I would be here at the papillary muscle and not at the correct regions of the chords. But worse than that, since the long axis is not a line anymore but a point in this view, we cannot be sure how angled it is about that line. The short axis could be any place, from here closer to the apex and angle to the base, or there, close to the base, and angle to the apex. The measurement, which is already not accurate, will lose now its precision. There are many other problems with evaluation of the left ventricle function as ejection fraction by this method. One of these issues is that the heart moves apically during systole and returns during diastole. Then, if we locate the M-mode cursor in a region, let's say it is here, the diameter that we see during diastole is not the same as the one seen during systole. Frequently, the systolic diameter will be much smaller due to the movement of the heart, and the cursor may be now at the base. If you have a sigmoid or angled IV septum, we may have a false impression that systolic diameter reduced significantly. If we are not considering the apical movement of the heart, the systolic motion toward the center of the cavity would be much less. This kind of problem happens almost in every patient, and it is more pronounced when the IVS is too much anteriorly angled, or there is a bulge at the basal anterior subaortic septum. Look at this patient. By eyeball, we are sure that the overall left ventricular function is bad. You have here a diameter of 6.6 centimeter and a systolic diameter of 3.7 centimeter with a normal ejection fraction of 71. Sure, it is not. It is due to the apical movement of the heart, while the cursor stays stationary. Notice that even the 2D short X view also demonstrates a better function than one seen in the long X view due to different locations of the view position from diastole to systole due to the movement of the whole heart in apical direction during systole. Another problem is the question of temporal resolution. You might ask, if it is so difficult to get a perpendicular short X diameter to the long X with M mode, why not to use only the 2D echo for this measurement? It appears logic. Why not get a steel frame in diastole and measure it right in here, perpendicular to the long X and at the correct position regarding the tips of the mitral valve? The problem is a question of temporal resolution of echocardiography. 2D echo has a horrible temporal resolution. When you look at a movie clip like this one, it seems that everything is moving correctly. One thinks that there is a uniform displacement of the structures. Pay attention to the mitral valve. It looks like it is moving continuously, not jumping from one place to the next. This happened because our brain integrates the image, giving us a false impression of a continuous movement. It is just like the movement seen in cartoons. Even if I study it frame by frame, I cannot be sure that this apparent maximal diastolic diameter might be more extensive if there were a couple of image frames beyond this point to the maximal diameter. If we repeat in a different situation with a minimal heart rate variance, the number of frames by one cardiac cycle will vary, and so the measurement. For instance, here we see all the movement as continuous, but watch the reality frame by frame. Here the mitral valve is closed, and then it started to open, and in the next frame it is already entirely open, and I do not see what happened to it or its position. It may have reached and touched the IVS and might be just returning from it. Moreover, I do not know its maximal excursion or have any detail of its real displacement through time. The same thing happens with the left ventricular wall. It is very difficult to be sure we measured the longest short X diameter. I may pause the frame right here and think that this is the largest cavity, but 1 or 2 frames right after that, the walls may have moved away and returned back, and then only seen in the next frame, and you will miss the largest cavity. This is the problem of measurements using 2D of structures that are moving fast. It does not happen with M mode. Look at the mitral valve. We can see exactly what happened to it during the whole cycle. No jumping. We can see it opening and even measure its opening velocity. This maximal approach to the IVS is the maximal one. The difference is that instead of just 40 or fewer positions per second, we see the M mode about 2000 positions per second. Here we have one cycle to the next, just 24 frames per second with 2D, while with M mode we would see 2000 positions per second. That is a significant difference. Moreover, what problem this brings to measurements? See here, I'm trying to get the smallest systolic diameter and going frame by frame. I got this 1 diameter, and at the next frame, at the same time within the cycle, this was the obtained diameter. A 9% variation, and it sure doesn't mean it may not be larger 3 or 4 bits later. See now what happens with M mode. We now have 2000 evaluations per second of the position of the wall. Notice that I can now demonstrate the exact moment it began to contract and move, and the exact moment it obtained its smallest diameter. There are some more problems with the concept of using ellipsoid as the method to evaluate volume and ejection fraction. One of them is if we consider the left ventricular shape as an ellipsoid during diastole, it changed its shape in systole and now looks like a geometric truncate cone. And then we should have an equation for diastolic volume using the ellipsoid, and another for systole using the truncate cone formula. Another problem is that the left ventricle cavity at each systole decreases much more the short X than the long X. Then, if it may be true that L equals 2D in diastole, it is not true in systole. And one should not use the same equation for volumetric assumptions for both situations. Another problem is if L equals 2D in a normal heart size, L is more extended than 2D in a smaller heart and less than 2D in enlarged one. No way you can use a single equation for such different hearts. Other problems? Yes. Any M-mode method for ejection fraction, the walls investigating must be representative of the whole left ventricle. If the base of the heart is normal, but there is an apical aneurysm, or all the walls are normal, except for a small area at the posterior wall where the cursor is at, Surely, there is no way to study the global function if evaluated by M mode. Thank God, there is an eyeball. As in this case, the function of the left ventricle is normal by M mode at the mitral tips, but horrible at the card's position of the cursor. Another method to evaluate the ejection fraction by using the same measurement as seen in the ellipsoid is the so-called Teichholz solution to measure dilated ventricles. The reason is that when the left ventricle dilates, it does mainly by enlarging the short X than the long X, and because of this, the long X is much smaller than twice the short X. In a normal heart, we may consider L equals 2D and use the ellipsoid. This does not happen when the left ventricle dilates. If you use the ellipsoid in a case like this, when the L is smaller than 2D, you can imagine that if we measure only the short X, believing that the long X is twice the size, we would have a left ventricular cavity that would be as dilated as here. Teichholz estimates a constant relation between the short D and the long X in ventriculogram during catheterization in different left ventricle size, and came to a correct equation for these larger volumes. Here it is. Caution: this is obtained in a population, and you do not know if this relation of the Teichholz is right for the left ventricle of your patient, as much as you were sure that the left ventricle has not the shape of an ellipsoid. It is not a solution. It may even be worse, since it's also related to the ellipsoid and uses a regression equation to obtain the volume and ejection fraction. However, it is everywhere in all apparatus. It is easy to do. It has years of use by all laboratories. It may be the less accurate even than the simple revolution ellipsoid. It tends to over-evaluate the ejection fraction, but is probably the most precise. In other words, if the problem is to compare the actual fraction with the same patients later on, after chemotherapy, for instance, then I'd rather use it, not as an indicator of the left ventricular function. This is very important. Pay attention. Not as an indicator if the left ventricular function has a normal, mild, moderate, or important left ventricular dysfunction. For this task, I use eyeball. However, if I must give a number for ejection fraction that is going to be compared later on, I rather offer this and report the method I used, hoping that the patient will return to the same laboratory, or at least does not have a symptoms to compare ejection fraction with Teichholz in this case.